It's one of those little known, little talked about, mysterious things. Hematomas.
Post-delivery, you're talking about?
Yep.
I hate them. I don't know anyone who likes them, but they can become a very, very serious emergency very quickly. So let's say there's a scale of them, and hematoma is just like, let's say after a delivery, an area either inside or most likely like on the vaginal wall or on the labia or somewhere on the vulvar area. There's bleeding, but there's not an open site for the blood to come out. So it bleeds kind of into a pocket or an area where there's some room. And then it can be anything from something small where you just see a small lump there where nothing to do about it, to something that is rapidly expanding where there's some kind of active arterial bleeding or venous bleeding into the pocket, and you see it growing and growing before your eyes. And sometimes what ends up happening is someone delivers, they have some lacerations, or you cut an episiotomy and you do your repair. And then when you're all done, there's some area that sometimes you can see it, sometimes you can't see it, that is rapidly growing while blood is filling that pocket. And if you don't see it right away, let's say it's just dripping in there very slowly, sometimes it's only recognized postpartum, like someone will go to the postpartum floor and the most common complaint is, I'm feeling pressure in my rectum. And that means that behind the vagina, there's some kind of expanding blood clot that is now pressing on the rectum. So a complaint of pressure in the rectum postpartum without any other real reason for that is a hematoma until proven otherwise. So that requires an exam. So what do we do about them? It depends on the size and whether we think it's something that would resolve on its own. So if I see a small hematoma in a labia, and what I usually do to evaluate it would be, I see something small, we put some pressure on it, maybe even an ice pack with some, I don't know, we call them laps, but these sponges, like big towels kind of like, and we put it on there and leave it for a little while. And then I return, take off the pressure, take off the ice pack and take another look. If it's the same size or smaller, I leave it alone. It will resolve over time, hopefully. If you're watching it and you see it growing, it has to be opened up and drained. So, and that could be at any point during the postpartum period, like from right after the delivery to a day or so, or usually doesn't last a day because people will be symptomatic and someone will have to go back and evaluate it. But usually it's right after the delivery. So while I'm sitting there doing a repair, or while I'm, when I take out the placenta or finishing up, you see something or feel something and it's getting bigger, it has to be opened up and you have to find the source of the bleeding and you have to stitch that source closed. And then you can put your pressure and your ice or whatever you want to do to make sure that it doesn't get too swollen or too enlarged or symptomatic. And hopefully if you found the source of the bleeding, you nip it in the bud and nothing else happens. The unfortunate thing is an unrecognized hematoma. And if it grows rapidly and a lot of blood gets into it, people can lose a substantial amount of blood from the blood that drains into a hematoma, even to the point of needing a transfusion sometimes. And a hematoma can do what we call track, which means it tracks upward. Because if it's under pressure and there's no outlet for that blood to come out in the genital area, then it will start to back up. And it's kind of like a garden hose, like the garden hose is supplying the blood to the area, but you're not allowing it to drain south of where it is. So it will go all the way up. And I've seen hematomas all the way up in the vulvar area. They can go into the pelvic cavity. They could even require surgery to open them up, drain them, find the source of the bleeding and stop it. Knock wood, I rarely have had them in my deliveries, but it can happen after a completely normal vaginal delivery. And of course, it can more often happen in a delivery that either is emergent or using instruments or where there's a lot of repair to do. So yeah, we don't like them, and they can be really dangerous.
Question about Pitocin causing tetanic contractions. I assume you've seen it at least once. How does it happen and what do you do about it?
So it rarely happens because Pitocin is always on a dial-up system. You never like start someone on 10 units of Pitocin. You always start them on one, and the rules are, or the orders are, go up by one every 15 minutes or up by two, whatever we decide we want people to do, until this particular contraction pattern is achieved. And the contraction pattern we're looking for is every 2 to 3 minutes with enough strength and force to dilate the cervix. So we watch the monitor, we count our units of contraction under the curve of the monitor. And the way it can happen is that, let's say someone is contracting every 2 to 3 minutes, every 2 to 3 minutes, but they're not strong enough to make cervical change. So sometimes maybe someone will continue to turn it up even though they see the contractions seem adequate. And sometimes then the contractions end up on top of each other. So if the contractions come so close that there's no break in the action, like every minute rapid fire contractions, that can be a problem because the baby really doesn't have time to recover in between. And that can cause a decrease in the baby's heart rate. Easiest thing, turn off the Pitocin. If you have to, you can give somebody terbutaline or give them an anti-contraction medication to relax the uterus temporarily while the Pitocin gets out of their system. But it becomes a real problem if every time you turn that Pitocin back on, that happens again. Then you're kind of at an impasse because what do you need to become fully dilated? You need regular, strong contractions. If you can't get them regular and strong, you're not going to fully dilate. So what other options do you have? I mean, if you were ready for Pitocin when they started the Pitocin, which means you are already ripened at the cervix, you weren't very early in the process. So if you gave Pitocin at the right time, there's not a lot of other options other than Pitocin to give someone to give them those contractions. However, let's say somebody did start it too early. Then you can kind of reevaluate and keep the Pitocin off, go backwards and say, maybe they weren't really dilated enough to start Pitocin. Maybe we can still use a balloon or something like that, or something that you maybe should have used earlier, because I believe induction is really a process. It really should be serial methods of getting someone to their active labor phase. So if someone's not much dilated, we use a balloon, we use Cytotec, we use Cervidil, we use all the different things to ripen, which I think could take 24 hours or more. And then once they're in the phase of more effaced, little dilated, things are happening, that's the time for Pitocin. So if it wasn't done that way, you might want to reevaluate, go backwards a little bit. I have had rarely the occasion where put someone on Pitocin, wasn't really doing what I wanted it to do, went backwards, put the balloon in, and then started again kind of fresh. But if you did it right the first time, you shouldn't really find yourself in that situation.